I'm recording this, so if someone's coming in late, this time I'm recording it to the cloud, so there should be no reason why you shouldn't get it. Every time I record it to my computer, I'm still trying to locate it. But anyway, all right. When we talk about the knee, we're going to talk about the femoral tibial joint and the patellofemoral joint. The patellofemoral joint, obviously, we can do joint mobilizations on the patella, and we can do joint mobilizations on the tibia and the femur. So knowing what we know about mobilization, and we know the rule, or the concave convex rule, what shape is the tibia? It's concave. So if someone was sitting and we wanted to increase, and they only had about 30 degrees of knee flexion, and we wanted to increase knee flexion, we would have to do a glide. In what direction would we perform that glide, Aldrich? In a posterior, anterior, inferior, which way would we glide that tibia?
Posterior.
Posterior. We perform a posterior glide. If we would perform a posterior glide to the tibia, what do you think, anybody, Rod Neal, what do you think we would do with the patella?
Sorry, you got cut off. Can you say that one more time?
Yes. If we were doing a posterior glide to the tibia to increase knee flexion, in which direction do you think we would need to glide the patella to increase knee flexion?
Down.
Okay, so inferior. So we would do an inferior glide of the patella and a posterior glide of the tibia to increase knee flexion. Okay? If we were going to increase knee extension, we would do the opposite, an anterior glide and superior glide to the patella. Okay? So we have the lateral and the medial condyles. We have the epicondyles, to which muscles attach, tendons attach. The condyles are attachments, articulations for bones. We have the medial condyle of the tibia, lateral, medial, I should say, and fibula. Initially, when we talked about the knee, we said that it was a hinge joint. It becomes a lot more complicated than that because it has a rotational component. The knee is supported by a lot of ligaments, and we'll talk about some. We won't talk about all of them. We'll talk about the medial and lateral ligament, collateral ligament, as well as the cruciate. And it's the most vulnerable. It's the most injured joint, and most difficult to do. With hip and knee replacements, the more difficult replacement to do is the knee, because the knee is just the hip has a lot more musculature around it than the knee does itself. So again, I said there was a rotational component, which we'll talk about, and flexion of the knee is generally functionally 120 to 135 degrees. Extension should be 0. We wouldn't have, some people have hyperextension of the knee due to ligament laxity, others have systemic hypermobility. But flexion is generally 120 to 125, and depending on muscle bulk. So if you have a large hamstring mass back here, the flexion is going to be less. If you're a very slight person, you're going to have more flexion. Being that this rectus on this side is a two-joint muscle, as you flex the hip, there's passive insufficiency that occurs, limiting the amount of knee flexion you have. So you would have greater knee flexion and during hip flexion. So in a supine position, when you flex your hip, you would probably measure the knee flexion as greater than when you lie on your stomach. But that's not necessarily true for everyone. When we talk about the screw home mechanism, we have to talk about whether something is weight-bearing or non-weight bearing. So if you think about, and the screw home mechanism is basically just because the medial femoral condyle is longer than the lateral condyle. So when we extend, the articular surface of the lateral condyle is used up quicker, while there's approximately a ½ inch that remains medially. So the medial condyle must glide. It has to glide in the posterior direction in order to use up all of that articular surface. Now, with knee extension and non-weight bearing, and the way to remember this, because you have to think about what moves. If you're in a non-weight bearing position and you're sitting on a mat and you're just extending your knee, what is the bone that's moving? It's the tibia, not the femur. The femur is fixed. So with knee extension in a non-weight bearing position, you get external rotation of the tibia. However, with knee extension in full weight bearing position, what is moving as you're sitting on the floor and your feet are fixed and you go to stand up. The bone that's moving is the femur. So in a weight-bearing position, the femur immediately rotates on the tibia. Okay? So the screw-home mechanism is such that when you're in a non-weight-bearing position, the movable bone is the tibia that externally rotates to complete the full range of motion. And what helps, well, not with extension, but unlocking the knee. Forget that at this point, because that helps unlock the knee when you're bending your leg. Forget that for now. Just know that in a weight-bearing position, it's the femur that needs to rotate, and in a non-weight-bearing position, it's the tibia that needs to rotate. Okay? Now, I put this in here because I'd like you all to try this. Now, you're not going to try it right now, but in order to understand how this works, and it makes more sense, and I think I have a video of it also, but have your partner sit on a mat. So usually we do this on the mats, on the high mats in school, and we have the legs dangling. So the knee is flexed to about 90 degrees. You draw a line on the skin. So you take a pen, draw a line between the tibial tuberosity and the apex of the patella. So you find the apex of the patella, you put your fingers around it, find it, draw a line from the apex of the patella through the tibial tuberosity, and then ask the person to do knee extension. So after completing full tibia on femoral extension, so what you're asking them to do is extend the knee, redraw this line between the same landmarks, and you'll see that there's a change in the landmarks. The line will be different because the tibia rotates externally. Okay? So I want you to try this on somebody at home. They're going to be sitting, on a bed or something, or sitting on a chair in the kitchen. If their feet aren't, even if their feet are on the floor, try to put a few pillows under them so that you could have the foot flat on the floor, but it's a little better if the leg just hangs. And draw a line between the tibial tuberosity and the patella, and ask them to extend, and then redraw that line between the same spot on the patella and the same spot on the tibial tuberosity, and you'll see there's a difference because of the external rotation of the tibia. I thought I had a video. Well, there's plenty of videos out there on screw-home mechanism, but this is a really, really good way to see that there is external rotation of the tibia in a non-weight-bearing knee. The Q angle, a Q angle is the angle, it provides information about the alignment of the knee joint itself. Okay? So it's the angle between the quadriceps femoris, the rectus femoris, actually the quadricep muscle, to the patella tendon. So here, you're going to take a line, you're going to look at the ASIS, and you're going to draw a line from the ASIS to the midpoint of the patella. So again, you find the patella, you palpate all sides of the patella, find the middle, draw a dot. You're going to take a line from the ASIS to the middle of the patella. You're going to take another line from the tibial tuberosity through the midpoint of the patella, and the angle here is known as the Q angle. Some books say 14 to 17, some books say 13 to 18. There's a little play on this, little variability. Bottom line is that it's generally larger in females because of a larger pelvis. And this angle also decreases when you lie down. So if you do it in standing, it might be greater than when you lie down. Okay? Or there may be a change in the angle. So again, what we're looking at the alignment of the knee joint. So we're looking at the alignment of the pelvis in relation to the leg and the thigh. Okay? So here, ASIS, midpoint of patella, tibial tuberosity, angle. All right? Does the Q angle change? Yeah, that the patellofemoral angle, you could have an increased Q angle or a decreased Q angle. This is normal, so he says, what is going on here?
Is it valgus of the knee?
Valgus of the knee could be secondary to anteversion. We don't know because this picture doesn't give us enough information. But we definitely see a valgus. All right? This we see as sort of a varus. It's not real significant, but it is sort of a varus. So this with a bow leg patient or a valgus deformity or varus deformity, you're going to see an increase in the Q angle with this person that has this valgus and a decrease in the Q angle with this person who has this varus. Now, there could be a lot of reasons why this is happening. That's not the point of this picture. You could have an externally rotated tibia. If you had an externally rotated tibia, then you probably see this because the tibial tuberosity would be out here. You could have, this angle can cause a subluxation of a patella. You could have a laterally displaced tibial tuberosity. So there's a lot of reasons why you can have an increase in Q angle. You guys don't know enough about it now to determine that. Just know that you can see an increase in the Q angle or a decrease in the Q angle, and that will give you information about this, that there's an alignment problem with the pelvis in relation to the knee and the lower leg. Okay? So here we see increased femoral anteversion. So as a result of this, you see a slight valgus of this leg, and you see an increase in the Q angle. This patella can be subluxed. It can lead to, you can have, as I said before, this laterally displaced tibial tuberosity, or it can be because you have the tibia that's externally torsioned. So there's a lot of reasons. We just can't look at a picture and say, oh, this Q angle, or you can't just measure somebody and say, oh, they have an increased Q angle because they have an anteverted hip. Maybe they don't. Maybe they have a tibia that's torsioned in an external direction or an internal direction, which will give you a decrease in that Q angle. So we have to examine all parts of what's going on. And in this particular case, this anteverted hip with this valgus will lead to a foot pronated. Okay? So again, don't memorize this picture, but know some of the reasons that you can have an increased Q angle. So you can have an increased Q angle from an anteverted femur, a sublux patella, a lateral displacement tibia, tibial tuberosity, and externally torsion of tibia, to name some. Okay. Decreased Q angle would be the opposite. A retroverted hip. Patella alta, does anybody know what that means?
Tell us higher than normal.
It was higher. What would one of the reasons be for the patella alta? What do you think?
Tight quads.
Tight rectus specifically, right?
Mm-hmm.
Right. So what would you have to do in order to modify that Q angle on that person? Just stretch the rectus. Okay? So that could be just a simple thing that you need to do. It's not always as simple as that. Just an example. So what do you see in this picture?
Oh, is significantly higher off the
Patella.
So where's the patellofemoral joint? Shouldn't it be here?
Yes.
Correct.
All right, look where that patella is. Okay, so that's a picture, an X-ray of somebody who has
Patella tendon?
patella alta. Excuse me?
Does that
I don't think.
I was just wondering if there's any like kind of tear or any kind of like.
I don't know. I don't know this person specifically. I just know this. I saw this picture. I thought it was a good picture. Picture of patella alta. Okay. So patellofemoral joint, what the patella does, one of the things it does is increases the mechanical advantage of the quadricep muscle as the quadricep muscle goes over the patella and inserts into the tibial tuberosity. It also protects the knee joint. We know what the patella looks like. It's a sesamoid bone. The quadricep muscle attaches. Distally, it's slightly pointed. Inferiorly, superiorly, it's broad. What is the function of the patella? As I said, it provides an increase in leverage of the quads. Because when you flex the knee, the muscle length is longer. That allows for a better length-tension relationship between the muscle and the tendon. So if someone has a fracture fracture of the patella, or they fall right on their patella and it shatters, and they elect to do a patelectomy. They don't like to do this, but in some cases they have to do it because the patella is so destroyed. Then when we rehab this patient, we need to increase their quads by at least 30% to perform knee extension. So these quads need to be a lot stronger in order to compensate for the fact that we have no patella. Difference between genu valgus and a genu varus is that a genu valgus can be, not always, can be secondary to medial collateral tears or medial collateral laxity. But remember I said can be because somebody's got an anteverted hip, can be because somebody's got osteoarthritis, can be because somebody's got a torsion of the femur. There's a lot of reasons why you could see either one of these. More common to see is a genu varus with someone who has things like osteoarthritis or rheumatoid arthritis. Generally, you see a varus form, deformity rather than the valgus. What's genu racavatum? Genu racavatum is hyperextension of the knee where the femur is posterior to the tibia. Can we think of any ligament that may be responsible for that? We haven't talked about it, but I think Kevin has been talking about it because you guys have been looking at special tests. Could be an ACL problem. So an ACL, what an ACL does is prevent anterior translation of the tibia on the femur and posterior translation of the femur on the tibia. So if I'm talking about the fact that a genu racavatum or hyperextended knee in appearance is that the femur is posterior to the tibia, that can be a direct result of an ACL tear. So, joint mobilizations, patellofemoral and tibiofemoral or femoral tibial. If I'm going to do knee flexion, I'm going to do a posterior glide with an inferior glide of the patella. If I'm going to increase knee extension, I will do an anterior glide of this joint and a superior glide of the patellofemoral joint. We know rheumatoid arthritis is systemic. Generally, what happens to one side happens to the other. The joint, we have these, and that's spelled wrong, I'm sorry. The joint, we have joint destruction, which may result in a total knee replacement. You could have a total knee replacement with OA also. Okay?
Professor?
Yeah?
Do you mind going back to the last slide? Oh, no, you're already on it. Okay. Can you repeat what you were saying and maybe explain a little bit more of the joint mobilization for the patellofemoral and the tibiofemoral? And you were saying in order to mobilize for the patellofemoral, you'd want a inferior glide. So, can you explain what that means or what you're doing there?
Okay. If you have...
Or superior, I'm sorry. Superior glide.
If you have your patella moves, right? You can move your patella. You can put your hand on your patella and you can move it. You can move it upward. You can move it downward. You can move it to the outer side, or you can move it to the inner side. The patella moves. And that's the whole thing about patella tracking. Sometimes you hear people say, oh, there's a lateral tracking of the patella. And some other people say, well, that's because of VMO, weakness, well, whatever it is. We know that the patella does move. So if I want to increase knee flexion, I would have to look at two joints in the knee. So we have a femoral tibial joint or a tibial femoral joint. Some people, as I said, we're supposed to name it from proximal to distal. But a lot of times you hear tibial femoral, you hear therapists use tibial femoral. They use that interchangeably. So if I need to mobilize the tibia on the femur, I also need to mobilize the patella on the femur. I need to mobilize both because it may be just, and not always, I shouldn't say 100% of the time, but I would certainly look at the patellofemoral joint to see if I have any restrictions there. So if I want to increase knee flexion, I would have to do a posterior glide of the tibia. You get that, right?
Yes.
Okay. But In knee flexion, normal mechanics are the fact that the patella glides down as I flex the knee. So it moves in an inferior direction. So if it wasn't moving like it should, I would have to glide it. So I would have to take my web space of my hand and I would have to place it superior to the patella and just push it in an inferior direction.
Oh, I see. To assist the movement. Okay.
Okay?
Yeah, and then what about, and so then would it be the reverse for knee extension? Would you have to glide it superiorly or no?
Yes.
Okay, if they were having issues. Okay.
Yes.
Okay.
Okay.
Thank you.
You're welcome. So we're going to talk about the ligaments, the cruciates, the collaterals we had in the elbow too. Remember we had a medial and a lateral collateral. Or we had what else did we call them? An ulnar collateral or a radial collateral. So in the leg, in the foot, in the leg, I should say, in the knee, we have a medial and a lateral collateral or a tibial or fibular collateral. We also have menisci. We have many bursa, because bursa are available anytime you have a lot of tendons crossing that joint. The popliteal space is in the posterior side of the knee, and pes anserinus is the attachment for 3 tendons, and they are, Dawn, what are the tendons?
I'm sorry, I'm having issues with my audio. What did you say?
Oh, pes anserinus, what's the attachment? What are the tendons associated with the pes anserinus?
Semitendinosus.
No, I asked Dawn.
Semitendinosus. Is it semimembranosus too?
No. Chris Spencer?
They're all fleeting.
Chris Spencer? Are you there?
Hear me?
Yes.
Okay, yeah, sorry. It's the semitendinosus, gracilis, and sartorius.
Right. Okay.
My headphones aren't working.
Okay. Genu, varus, and valgus. This is normal, genu valgum, genu varus, right? So which one has patella squinting or patella pointing together? More like this, right? This person looks like they have a lot of other problems too. Look at this. So this looks like, what do you think this looks like to you? We look down here. This is a great picture of a varus. See that? So you can see that the compression is here, the distraction is here, right? Here, where's the compression and where's the distraction? Here's the compression and here's the distraction. So where you're going to have more ligament laxity with this valgus? I'm pointing to it, guys.
Yes.
Medial collateral.
MCL.
Right, medial collateral, right? And where you're going to have the compression? So where's joint pain going to be? Maybe lateral. Some compression here and some distraction here. Okay. What else do you see here? A lot of stuff, right?
Feet. Yeah, a lot of stuff going on with the feet.
A lot of stuff going on with feet. So you could probably figure this guy's got some kind of systemic stuff going on because it's bilateral. So this is unilateral. So maybe this is OA and maybe this is RA. Because there's a lot of different changes in the feet also. Just like in the hands, you have that drift.
Yeah, so with the wrist, we were it was like ulnar drift, so like in the feet. I mean, my eyes are terrible.
No, you're correct. You're correct, Joe.
Yeah.
So you have the drift. You have a. They don't call it a specific drift, but yes, you do. You have that. You have that hallux valgus here, and then you have hammer toes, and you have all kinds of things going, deformities in the toes. All right. So genu recurvatum, neutral. So we see what's happening. This is neutral. You drop a plumb line, it's neutral. This is genu recurvatum. Okay?
So, Professor, real quick, when you said before you could have hyperextension from laxicity in ligaments, but you could also have hypermobility. Is there a difference? Like, are those the same thing, just used interchangeably, or are they difference between the two?
Well, systemic hypermobility would mean there's like 9 things that you look for. Systemic hypermobility. You look at the person's entire body. That's a real pathology. But just hyperflexibility or, just laxity may just be in one or two joints, as opposed to something systemic.
Okay.
Professor.
Yes.
Yeah. So for valgus, well, I know like for rickets, like I think it's called rickets, like when children have like insufficient amount of calcium, right? I think you will see valgus knees, I guess, or no.
You usually see varus. You see more bow legs. Yeah.
Oh, okay, varus. Okay.
Okay, so this is your new record bottom. So if I look at somebody, how do I make the difference between, or how do I make the observation between this and this? Genu valgus, genu varus, as opposed to genu record bottom. Obviously, when I look at genu valgus, I have to look from an anterior posterior view, right?
Mm-hmm.
If I look at record bottom, I need to look at them from a lateral or sagittal view. Yes?
Yeah.
At times when if somebody's serious enough or severe enough, you could actually look at them from an anterior posterior view and see this. But generally, we observe this from a lateral view.
So, is this due to primarily just due to issues with the ACL, or could this also be like from quad weakness or?
Could be could be tightness in the gastroc, could be quad weakness, it could be some pathology going on at the hip, it could be coming from your trunk, there could be a lot of things, could be from your foot. But if I'm talking about ligaments, an ACL can, if you have an ACL tear or an ACL weak, sprain, what's the word I'm looking for? Laxity. You can have genu record bottom.
Okay, excellent. Thank you.
So that may be one of the things you can observe.
Professor.
Oh. Yes.
I just want to ask this really quick. I'm not sure you talked about this before, but does coxa valgus and coxa vera, does it affect the genuine varus and valgus?
The Vera and valgus may. They may, but I did talk about this because I said one may have an impact on the other as far as if one causes anteversion. If a torsional problem can cause a valgus, then it may result in a varus at the knee. But we're talking that stuff gets really complicated. And it's really on an individual basis. You just can't say one is causing the other to happen. But yes, you could see a variation of it. You could see visible malalignment syndrome, and that what they have to do is they have to go in and they do osteotomies. They cut and they realign, and then they put somebody. They may even need to put a Wagner device on or a leg lengthening device on, especially if it affects the epiphysis. So there's a lot of different things that they might need to do. But yeah, at this point, I just want you to know what they are. Okay. Posterior cruciate, anterior cruciate. So here, what I always show you in class is I cross my third finger over my second finger. So I don't know. You guys can't see me, right? No, can't see me. So take your third finger and cross it over your second finger. Like you're making a wish. That third finger is the ACL, and the second finger is the PCL. That's the appearance that it has in the knee. Mm. So if we look at this picture, we could see that if we look at the lateral condyle, and we look at the posterior cruciate ligament, this is the anterior cruciate ligament. Now think about from this femur to here, it's just what I'm telling you, how am I going to explain this? From the femur down. So think about, when I asked you to cross your hand, put it on your thigh. And the ACL is running from the lateral to the medial, and the PCL is running from the medial to the lateral. So whenever you see a picture, and you could see that this is lateral because this is fibula and this is tibia, this will be the ACL, and this will be the PCL. Just think about that finger crossing, okay? So this is the ACL. Here's the lateral collateral ligament. You see it is not attached to the capsule. This is the medial collateral ligament, which you see is attached to the capsule, as well as the meniscus here. So, which is more vulnerable to injury? Right over here. So, if you have an injury to the medial side, there's a lot of stuff that can be the meniscus, the ligaments, the medial collateral ligaments. And there's something known as a transverse ligament, which goes this way. And then we have the condyles of the femur. All right, on the medial side, we have that medial collateral, medial meniscus, medial condyle. All right, on the medial side, we have all this is attached to the capsule itself. Here we have the head of the fibula, and we have the tibial tuberosity. So if you saw this drawing, there's no way that you could mistake what anything is, right? This is a lateral side fibula, which would be the fibular or the lateral collateral ligament. Medial side, medial collateral ligament. ACL crosses over, PCL. ACL from lateral to medial, PCL from medial to lateral. So there we have the cruciate, anterior cruciate. All right. Inside the joint capsule, we have intercapsular ligaments. You're not going to have to be responsible for that at this time. But we do need to know about the cruciates. They're responsible. They have a stability in the sagittal plane as well as some stability in rotation. Okay? And they're named by their attachment on the tibia. So, here. Place the palm over the knee. So, over the thigh, as I said, right above the knee. Flush your third finger over the second finger. And the third finger will be the anterior cruciate, and the second finger will be the posterior cruciate. You're all good with that, right? Yes? Hello?
Yes.
Yep.
Yes.
Yes.
All right. All right. So the anterior cruciate runs from the anterior tibia to the posterior femur, and it prevents, this is what's important here, because we just talked about all this, prevents anterior displacement of the tibia on the femur, but we have another bone, right? So if it prevents anterior displacement of the tibia on the femur, that means the tibia coming forward, then it's got to do something with the femur itself too. So it prevents posterior displacement of the femur on the tibia. Okay? And we have anteromedial and anterolateral bundles of the ACL. Again, that's a little bit more complicated, so things change when we discuss those. For right now, we're going to say that the ACL is tight during extension. Okay? So the ACL is tight during extension, and it's looser during flexion. Okay? Prevents anterior displacement.
Well, so would that mean the opposite is true for the PCL?
Yes, it's tight during flexion. Okay? The PCL provides, or I'm sorry, the ACL, the PCL prevents posterior translation of the tibia on the femur. Therefore, it prevents anterior translation of the femur on the tibia. Okay? So just remember one. If you remember the ACL, it prevents that tibia from going forward. So when you're going to have problems with this knee, think about walking downhill. Think about doing those eccentric activities, right? That tibia is going to come forward. You're going to feel it. All right? So a lot of times with these patients, with these ACL patients, what kind of exercise do you think we give them? What test do you do for the ACL?
Anterior draw.
Anterior draw, and what else?
Lockman's.
Lockman's, right. And why do we prefer Lockman's over the anterior draw?
Because it gets rid of the hamstring.
Okay, so with an anterior draw, you can get a false negative, right? Why can you get a false negative?
Because you have hamstring activation
Because
with
the
that.
hamstring attached to the fibula and the tibia, and they could act as stabilizers, right? So what muscle do you think you want to strengthen with an ACL laxity?
Hamstrings.
Absolutely. Absolutely. So would you walk forward on a treadmill or backward on a treadmill?
Backwards.
Backwards, because we want to recruit the hamstring muscles. Absolutely. So ACL, PCL does the opposite, and it's tight joint flexion. So when do we have a PCL tear or a PCL? ACLs are very common. PCLs, we can fall right on that knee at that hyperflex knee, get that translatory process going on from the tibia in the posterior direction. Can also hit the dashboard. A lot of times, I should say always, but many times it's associated with a passenger that the knee hits the dashboard upon impact and causes the tibia to translate posterior and tear the PCL. Okay? So PCL may result from that fall, that hyperflex knee, that fall in the tibia, or some kind of a force coming from an anterior posterior direction, motor vehicle accident where the knee keeps going into the dashboard and pushes that tibia in a posterior direction. With PCL and ACL tears, it's not uncommon to have joint effusion. So or hemarthrosis, blood in the joint, and a lot of ecchymosis, a lot of swelling. You could also have non-traumatic patellofemoral dysfunction. Could be poor tracking. So this patient can complain to you about pain going up or down stairs. They have a positive moviegoer sign. What does that mean? It means you sit in the movies usually and you watch a movie for about an hour and a half to 2 hours. Years ago, sometimes they were 3 and 4. Person gets up and starts to have twinges and a stabbing pain in their knee from patellofemoral dysfunction. Okay? Forget this, we just talked about that before. Mechanism of injury, ACL. ACL is usually a twisting or a torsional injury, or your body rotates while your knee can't because the foot is fixed on the ground. So you have a change in velocity or a change in position really quickly, and you can tear that ACL. It's a twisting, usually occurs with torsional injuries. Okay? Foot stays planted, tibia or femur moves in the opposite direction. Or with this, all right? What would you say that was? Pretty much
Oh, God.
hyperextension, right? That femur's going hyperextension.
That would be more PCL though, right?
No, well, this femur is going back. So this hyperextension, hyperextension is associated with the ACL tears, right? So in this particular, the tibia is forward, but the femur is going back.
It's also posterolateral impacts, for, like say hits from behind that can to the lower leg that knock them out, right?
Absolutely. And sometimes there's non-traumatic ACL tears. You just happen to twist. Your foot is fixed, and you happen to twist, and the velocity is very great, and you're stopped, and you turn quickly. You jump, you come back, you land. You're playing basketball, and then bingo, you feel a pop. As you come down, you start to turn your body, and your leg is fixed, and bingo, there you go. All right. This isn't a great picture. I try to find an orthoscopic view, but they're hard to see. Scopes are hard to see anyway. They do operative arthroscopies, and they take a look what's happening. So obviously you guys know what this is, right? Here's the fibula. Here's the tibia. Here's the lateral collateral ligament. Here's the medial collateral ligament. That's all this. And there's that third finger going over that second finger. So if you see a picture and it says what structure is torn here, what are you going to say?
ACL.
Yes. Okay. Mechanism of injury. I show you another picture. Hyperflexion of the knee, right? Here the impact, the ground hits the tibia in the posterior direction, or the leg hits the dashboard.
Should have had a seatbelt on.
Yeah. With PCL, you see a posterior sac. So you're looking at what they're doing is they're doing right before they do surgery. And they're looking at what's happening with the tibia. See that sac? So it's a posterior sac sign. Here it is too. So this person is just lying here, and then I like this because the bones are superimposed on the skin. And this leg is nice, the tibia is out, and in this picture you can see that the whole leg appears to drop in the posterior direction. Okay? So the stag's nice. Here's another picture of it, and there's a video. Might as well show it.
Hi, my name is Kurt Stevenson. I'm an athletic therapist at St. Mary's University. I'm going to go over a posterior sag test for the knee. If it's positive, it's positive for PCL, strong PCL. So I'm comparing both knees with the athlete lying in supine, knees fully straight. I'm going to get you to bend your right knee up.
I don't see a video, dude.
Looks like a normal knee.
Oh,
And the other one up. And what you can see is how the entire stiff complex has shifted posteriorly. So that is a positive.
I see it, just the audio.
Don't see a video.
Yeah.
you guys didn't see it?
No,
Just here.
just audio.
Oh,
I can assume that the posterior sag test is just like an opposite McMurray's, right? Where you instead of
I don't know why, because I'm sharing the screen. So, hold on. New share. All right. Wait a minute. Let's see it. Hold on. Can you see it now?
No.
My name is Kurt Stevenson. I'm an athletic therapist at St.
All right. Well, you guys have it in your video, so just take a look at it, okay? Sorry, I don't know why that happened because I was sharing, so I don't know what happened. But just take a look at that. All right. Ligaments, medial collateral, is also known as the tibial collateral. Flat is broad, it attaches to the condyles of the tibia as well as the femur, or also attaches to the meniscus. That's an important thing, okay? To the capsule as well as the meniscus. So you can imagine it getting blown out. Sometimes the meniscus can get blown out too, right? This is just attached to one from bone to bone. From the lateral round, it's cord-like, runs from the condyle to the fibula. No attachment to the meniscus. Very strong. It's seldom injured. This one's much more injured. Medial collateral. So prevents excessive motion from a blow to the lateral side, right? The medial collateral provides medial stability. The lateral collateral provides lateral stability. And they're tight during extension, and they're slack during flexion, right? So why did you have to bend the knee 20 degrees? To take the bone-on-bone configuration, the congruity, and to look at the integrity of the collateral ligament. Okay.
And so that would be the open packed position is how you,
Yes.
for the knee.
Yes.
20 degrees.
Okay. Ligaments and other menisci. Ligaments and other menisci. We'll talk about, we're not going to talk too much about all the coronary and different ligaments that are in the knee itself, but we will talk about meniscus are important for shock absorption. From this picture, which one looks bigger?
The medial side.
Yeah, the medial side is C-shaped and it's larger than the lateral side. So it's C-shaped and it's larger. And what are menisci there for? Because they're fibrocartilaginous discs. What's the strongest cartilage we have? Fibrocartilage. So what are they there for? Not only to deepen the joint surface, but also to provide some shock absorption. Okay? Otherwise, we'll have bone on bone. So medial meniscus is torn more frequently. It's also involved because the medial collateral attaches to this. It's larger, it's C-shaped. So the lateral meniscus is more O-shaped and it's smaller.
So the lateral is smaller.
Yes.
So this is correctly labeled? Lateral.
This is, yes. Yes.
Okay.
All right. Clinical presentation. If somebody's got a medial or lateral meniscal problem, we have learned to do something known as the McMurray test, right? Do you do a McMurray's test where you're looking at the medial collateral ligament, flex the hip and knee, and provide a valgus stress as we're going into extension of the lower leg? And we're looking for medial meniscus problems then. Medial and lateral meniscus, a patient can many times just point to the joint line, the joint space. Because if they point to the joint space, you're pretty much looking at meniscus, okay? And clinically, these patients say they complain of locking. They have pain, they have swelling, they go down the stairs, it locks. It just feels painful, okay? Ligament tears, you have instability. So walking on even surfaces, walking downstairs, walking down a hill. However, there are a lot of people that have, and they put braces on people that have ACL tears, and a lot of times they don't do surgery. Well, if you don't have a lot of instability and you don't have pain, why would you get surgery? Because I will tell you that many people that have ACL repairs and any kind of surgical intervention wind up with osteoarthritis later on. And a lot of them wind up, the ACL tears are very common in women too, women athletes, because the Q angle is larger, the ligaments are more lax, and then people wind up with OA and knee problems. So that's the clinical presentation of both. Let's see, ACL, that's another picture. All right, there's something known as a terrible triad. It's also known as the unhappy triad. In some books, you will read it as the O'Donoghue's triad. There's three things happening. You have a tear of the medial collateral ligament or tibial collateral ligament. You have a tear of the medial meniscus, and you have a tear of the ACL. Tackling. This could be one result. I mean, it could be some kind of contact sport, some kind of contact activity, where he gets hit from the lateral side, causing a valgus stress, right? Foot is planted, it's torsion. You get bing, bang, boom. The meniscus is out, the medial collateral is out, and the ACL is out. Okay? So that's the definition, or that's what's happening when you have the terrible triad. What do you think of that? You like that?
No.
So the leg is over here. Would you call that a valgus stress when he's leaning his body over this side?
Yeah, a little bit.
Yeah.
I would. So this guy, this soccer player had an unhappy triad. He was an unhappy soccer player after this.
That's Nemanja Vidic.
You know?
Thanks, Steve.
Yeah,
No?
well,
Okay. All right.
Professor, I have a question.
Sorry.
I have a question. Okay.
So what rotation does the tibia go in order to injure the ACL?
What do you mean, what rotation?
When we talk about mechanism of ACL, you talk about the pivoting and
Well,
stuff
the foot is fixed.
of.
The foot is fixed, and the femur can rotate, or the tibia can rotate.
Oh, so it doesn't matter which way it goes. It will just injure the ACL.
It's a rotational injury.
Okay then.
All right. Anterior, posterior, lateral muscles, anterior, these are one joint, right? Vastus lateralis, medialis intermedius, two joint, rectus femoris. Posteriorly, we have biceps femoris, two joint muscle, yes? As well as the semimem 10, sartorius, gracilis, gastroc. And laterally, the two joint muscle. Is that a two joint muscle?
Because the TFL goes, the IT goes all the way down to the knee.
If you consider it going all the way down to the knee, yes. Okay. So if you had a state board question, which of these muscles in the anterior compartment are two joint muscles, you'd have to say rectus femoris. Okay. I won't go here because you have this. So gastroc, other muscles, let me see. Anterior stabilizers, bursa, a lot of bursas in the knee. The bursas to reduce friction of the tendons and a lot of tendons and muscles around the leg itself. And we have a femoral bursa, we have a prepatella, infrapatella, deep infrapatella. Don't worry about these, just know that we have a lot of bursa in the knee. This is just a location of where they are. I'm not going to hold you responsible for them because, as I said, anything that, when we talk about all the amount of tendons and muscles in crossing the knee itself, there has to be a bursa in there. All right, popliteal space, we said that the popliteal space we have, what's back here, the common peroneal nerve, the popliteal artery vein, the tibial nerve. On the medial side, it's the semi-tend and semi-med. On the lateral side, the biceps more. And then we have the gastroc attaching to the medial lateral. Pezantheritis, goose foot. I've heard that a million times. Sartorius is first. Cristilla second. Semitendinosus third. Makes a creaking popping sound every time I get in and out. He's talking about the car. Right? That's just your knee, sir. That's a stupid joke. Okay. So an X-ray. What are we looking at with an X-ray? We're looking at to see if the spaces are symmetrical. So does this space look different from this space?
Yeah.
Yeah. Yep. So where's the OA? Over here, you can see even a little, some tiny bone spurs that are developing. Okay, which you don't see on this side. What's this?
The prosthesis.
Total knee replacement. So it's not mine, thank you.
How do you know? How can you?
Because it's bright white on the X-ray.
You can.
Yes, it's bright red on the X-ray, and you can see that little stem. And
Yeah. What's it made of?
Titanium. Most probably. Yeah. All right. Let's go to the ankle. We're going to finish the ankle, and we have time. So we're going to talk about some ligaments, and we're not going to talk about all of them, but we'll talk about the ones that are most important. The ankle, we could see here the fibula, tibia, and we can see a lot of ligaments here, right? So all these ligaments in the tarsals and between the cuneiforms all have ligaments. They have ligaments here. We have a lateral collateral ligament complex, which is the anterior, the ATFL and the PTFL and the calcaneofibular ligament. You've done a test for the calcaneofibular ligament, right? That test is the talar tilt, and you've done the anterior jaw for the anterior talofibular. You have videos of it, right? To look at these specific ligaments. So they're named for where they go. So the ATFL, or anterior talofibular ligament, comes from the, you can see, comes from the fibula to the talus, right? It's from the posterior talofibular ligament, from the talus to the fibula, right? Calcaneofibular ligament, from the calcaneus to the fibula. All right. On the medial side of the leg, we have a very, very strong ligament known as the deltoid ligament on the medial side of the foot, I should say. Okay. So talocrol joint, that's between the talus and the tib, right? 1 degree of freedom, dorsiflexion, plantar flexion. Subtalar joint in an eversion, mid-tarsal joint, supination and pronation. An amputation that occurs at the mid-tarsal joint is known as Chopard's amputation. So, mid-tarsal joint. So what's happening at that mid-tarsal joint? Supination and pronation, right? So can this person still in an evert and dorsiflex? Sure.
Yes.
Right. A pronated or an everted foot can be known as valgus, referring to the foot position. And we also know at the distal tip strip, we know this from bones, we have something which is fibrous attachment, which is known as syndesmosis, which allows or engages the talus to come to, as we're dorsiflexing the foot, makes room for the talus. And at the metatarsal phalangeal joint, we have 90 degrees of flexion, and that can be seen when you're standing on your toes. So when you're standing on your toes, you have metatarsal phalangeal flexion and extension of the distal bone from that. So the DIPs and the PIPs are extending, or the MTP are flexing. So that's flexion. So here's the show parts amputation.
Whoa.
They do. And that's what it looks like. There you go. All right. Did I wake you up? Hopefully, some people, while he's still looking.
Jesus Christ.
Yeah, so that may be secondary to necrosis, tissue death. What's the most common reasons for amputations other than if it wasn't trauma? What's the most common reasons for amputations? Diabetes.
Fish.
Okay. Diabetic neuropathy. Right? People wind up with amputation. So that's a show part amputation. Pronation. If we pronate, what's pronation? Left walking inside of the foot. But what is pronation? What is pronation in non-weight bearing status? That's really on
it's
the
inversion, abduction,
It's dorsiflexion, eversion,
abduction, and eversion in a non-weight bearing foot. What's pronation in a weight bearing foot? The tibia is internally rotated. The talus is adducted and plantar flexed. And the calcaneus is everted. Okay? When you weight bear, everything changes. There's a force called when the foot hits the ground. Everything changes. And it's true. So when you have a pronated, when your foot is pronated, what's happening is you have calcaneal eversion, talus adducted plantar flex. Okay? The bones above it move. And the tibia internally rotates. And a lot of times the knee is flexed. So when you're in supination, you usually have extension of the knee, and the talus abducts and dorsiflex, and the calcaneus inverts. Okay? So there's a difference between weight-bearing pronation and non-weight-bearing pronation. We'll talk about that more when we talk about gait. All right? I will not ask that kind of question on this final exam. I just want you to remember it. Okay? Supination loads on the outside of the foot, and this is all changing, right? All right. Pes valgus or pes planus. Planus is flat foot, valgus. In children, it looks like a flat foot. It's usually due because the medial longitudinal arch collapses, and this kid may have tightness in the calf or laxity of the Achilles tendon. Okay, just know that that's what it looks like, flat foot. Pes varus or pes cavus, cave meaning that you have a higher arch. It can be hereditary, or you could have tightness in that medial longitudinal arch. It can result from orthopedic or neuromuscular problems. Okay, these are all types of dystrophies that you may see a child have that appearance of pes cavus or pes varus. And equinus or equinovarus, it means equinus is horse. So think about a horse. Your horse walks on its toes. So equinovarus is walking on your toes. Equinus is walking like toe walking, and equinovarus is toe walking with inversion or adduction, plantar flexion and adduction. Okay, and pes or talipes, I forget how to say that. Talipes equinovarus is when you have, again, plantar flexion, calcaneus, and this is forefoot. Supination will result as this varus deformity occurs. And this is really, what this is known as clubfoot. This usually happens in utero. Okay, and what they do is they cast the baby when they come out. And because everything is still growing and everything is very flexible and moldable, it winds up in a normal foot. But the child may come out looking like this. So here's a picture of it. It's known as clubfoot, and that's what I always call it, clubfoot. Okay? The foot is usually smaller. The foot may point downward and inward. The front of the foot can be rotated. It's congenital. May occur in one foot, may occur in two. Once they splinter, they cast this kid, it's normal. My brother was born with bilateral club foot. Okay. Only problems he's ever had is he used to run and he would always get shin splints. But then when I looked at his foot, he had because he's older, and years ago what they did is just cast you to keep your foot normal. What they did is they supinated his forefoot and pronated his rear foot. So he has to get a modification in his shoe. But other than that, he's fine. So, like I said, these babies are born with this. Usually happens in utero. My brother, actually, I was larger than, my mother was smaller, and we were pretty big kids. So, that happened in utero. Okay. Plantar fasciitis. There's a tear of the fascia becomes inflamed. Fascia is located from the medial side of the calcaneus and runs down to the metatarsals. So this fascia, pretty classical. This patient has plantar fasciitis, will report of excruciating pain or pain greatest when they take their first step. So whether it's at 2 o'clock in the morning when they have to go to the bathroom, or whether it's they don't go to the bathroom at all during the night and they wake up and they take their first step. So the first step is the most painful. Okay? Plantar fasciitis. You get a micro tear of the fascia. You could treat this with ultrasound. You could treat this with orthotics. You could treat this with taping. You could treat this with stretching. Ice and stretching. Okay. We talk about arches. I'm not going to ask you to repeat to me a lot of the arches. We have a medial and lateral longitudinal arch. They both run from the calcaneus to metatarsals. We have transverse arches, which run through the cuneiform, so not only longitudinal but transverse. We have a ligament, and don't worry about these because I'm not going to question you on these. Okay? I just put that there to let you know that we have a lot of ligaments supporting the arch. One of the most important things for the medial arch or for the arches of the foot are the stability of the tibialis posterior muscle. You remember the tibialis posterior attaches to a lot of things on the bottom of the foot, and that maintains the arch of the foot. So if we have problems or tear of the medial of the tibialis posterior, we could wind up with a flat foot, and we could have what they call posterior tibialis dysfunction, which would certainly require some kind of a orthotic, some kind of an orthotic. Okay? So I just want you to know the arches, as we referred to, a flat foot. The arches can increase and make your appearance of having a high arch, or arches can be decreased, and you could have a low arch, but it's usually associated with ligaments. Okay? The most commonly injured ligament in the ankle is the anterior talofibular ligament. That's the most common. Then you could have the posterior talofibular ligament and the calcaneofibular ligament. They all resist inversion. So what's the mechanism of injury for this? What's the mechanism of injury for an ATLF tear?
Eversion.
Plantar flexion and inversion. All right? This is the mechanism of injury for this ligament. Think about when you walk down the steps and you miss a step. Your foot is plantar flexed and it's inverted. Think about when you're walking along and you step in a hole. Your foot is plantar flexed and inverted. Sometimes not only do you twist your ankle, but then you fall on top of that ankle. And you really stress those structures on the lateral side of the ankle. Okay? So know that. Know that this is the most commonly injured ATFL. Okay? And how do we stress that ligament in order to see if we have laxity? We do an anterior draw. Okay?
What about talar tilt?
A talar tilt is for the calcaneofibular ligament.
Oh.
Okay? Okay? More specifically. Now, there are a lot of ways you could, the way I do this, when I do an anterior draw, I'm looking to see if I have a pure sagittal movement or a coronal movement also. If there's a coronal movement also, I'm thinking that I have a posterior talar fibular ligament and possibly a calcaneal fibula. And then I confirm it with the supination and pronation of the calcaneus, looking for the calcaneal fibular ligament. But yes, talar tilt can be done to also to be more specific to look to that calcaneal fibular ligament. On the medial side, this is very hard, very hard to tear. It's usually very rare to get your medial or your deltoid ligament. The deltoid ligament is a very strong ligament from the medial malleolus to the navicular, the calcaneus, and also the talus. This ligament resists eversion, and it's rare. Usually you have to have an avulsion of the medial malleolus first. If you have an avulsed medial malleolus, and this is like really with severe forced eversion. So you don't see this much at all. I think I saw one in 35 years. But this is much more common. A supinated foot is the closed packed position for the foot. That allows for propulsion. A pronated foot allows for accommodation or adaptation to an uneven surface. So when we first hit the floor, when we ambulate, and we'll talk about this next semester, we hit the floor in a locked position, a closed packed position to absorb the shocks associated with hitting, with heel strike. And then once we strike the floor, then the foot will pronate and accommodate. Think about when you're walking on sand, okay? So you can't just don't put your foot out into a supinated position. It then pronates. So it allows for that foot adaptation. All right. Here's a really, as I said to you, you do not have to know this. I just put this in there to show you how complicated it is. All right. You're more responsible for the anterior, posterior talofibular ligament and the calcaneal fibular ligament. Okay. We talked about ligament testing, and this is what I said before. I didn't know I put this in here. Stabilize the distal tib stiff with one hand, grasp posterior calcaneus with the other. You pull a calcaneus in the anterior direction. If the calcaneus moves forward in that straight plane, you may have ligament laxity. So anterior displacement with a rotatory component will indicate greater involvement to the lateral medial structures with rotation toward the less affected side. If that doesn't make sense to you, don't worry about it, all right? If I had you in class, I'd be able to show you a little better. I'm going to ask Professor D'Onofrio just to demonstrate this or to videotape it, because I could pull you in an anterior, posterior direction or pull you in do an anterior jaw. If the left foot starts to move in an anterior or posterior direction when I do that, there could be greater involvement of other ligaments rather than just the ATFL. Okay. Thompson's test. Thompson's test, how do you do it?
Squeeze the calf.
Squeeze the calf.
Yes.
Yeah, you lay prone, flex the
And you
knee,
should look
squeeze the calf.
for
Right.
an flexion
Yes.
of the foot.
An flexion of the foot. But why? Because the gastroc and the soleus and the triceps surae, which are the gastroc and the soleus, insert into the calcaneus, right? So if they're not attached and you squeeze the calf, the foot won't move because those tendons are not attached to the calcaneus making the foot move. So that can give you indication that you have a rupture of Achilles. I don't know what this is a picture. Let's see. Hold on. Oh, you can't see this either.
Talar tilt test.
No.
Calcaneal.
All right, I want you to look at that. That's a talar tilt test.
Yeah, I think it only screen shares one browser at a time, so whatever.
Okay. So ankle sprains, grade 1, mild swelling tenderness, no loss of motion, no loss of ligament. Grade 2, you'll have edema, pain, ligament laxity, antalgic gait or decreased ambulation, and the range of motion will be limited. Grade 3 is a complete rupture or an avulsion. It's unstable. That person really walks like they have pain. So foot flat gait. So they don't want a plantar flex. They don't want a dorsiflex. They just want to land foot. Heel strike and toe off are absent. So they don't want to come down on their heel and land on their toe and then plantar flex. They just want to walk. Now, when these people walk and they take a step, the step length will be different on the right and the left side because you have two steps, right? When you step with your right and then you step with your left. That's a complete gait cycle. Take a step with your right and take a step with your left. Which step length do you think will be shorter?
Oh, the affected side.
The affected side will be shorter?
And then the non-affected side would be a longer step length because they don't want to spend more time on that affected side. Does that make sense?
Okay, the shorter step length will be on the non-affected side. Because they'll be...
So they're going to favor it more, so they're going to try to get to it faster, correct?
Right. And when we talk about gait, well, I'll explain that again. You don't have to know that for now. Just know the difference between a grade 1, a grade 2, and a grade 3. So what's our treatment? RICE. What does RICE stand for?
Rest, ice, compression, elevation.
Soft tissue massage you can do. You can also do...
Didn't they just change the RICE acronym?
Transverse friction massage. So you could do transverse friction across the tendon, across the ligament, I should say, which we'll talk about tomorrow because I have to talk to you about some massage tomorrow. So we're going to treat the pain and edema. With stage 3, you're going to have such instability, you're going to need surgery. Sometimes it's grade 2. Sometimes grade 2, if you have you have ligament laxity, so you have instability and you have a lot of ecchymosis. Ecchymosis is that black and blue. They may put you in a walking cast. They may cast you, okay, to prevent a lot of movement. Grade 3, usually what they do is surgery. Okay, what's a high ankle sprain? High ankle sprain is not only the tear of the ligaments, but it's also tear of the ligaments that attach the fibula. So here's interosseous sprain. So these interosseous ligament or the fibrous connection between the tib is also torn. Not only the ATFL, but also the syndesmosis. So you have those adjacent ligaments are also torn. That's known as a high ankle sprain. Okay? So you see here a sprained ankle occurs following a sudden swift movement in plantar flexion and inversion. And a high ankle sprain will involve those ligaments that also attach the fibula to the tibia, not only the ATFL and the calcaneofibular ligament. Sinus tarsi. The sinus tarsi contains the posterior tibial nerve, the artery, and the vein, and the talocalcaneal ligament. And that's, here it is here. Subtalar joint, calcaneus, here's the sinus tarsi. All right. Shin splints. Shin splints pain on the tibia itself. It's an overuse caused by inflammation of the periosteum. So a lot of times you'll see shin splints associated with young kids, and these shin splints and as this ligament also attaches to, there's something known as Osgood-Schlatter's disease, which the ligament will start, the patellar ligament will start, or the quadriceps ligament, you'll have an inflammation here, and the quadriceps ligament will start to tear off because the bones are growing faster than the muscles and the ligament attachment. Turf toe. Turf toe is forced hyperextension of this great toe at the metatarsal phalangeal joint. So you can see it. You can see it here. And it winds up with that ecchymotic area, that black and blue. Pes cavus versus pes planus. Before I said here's pes planus, flat foot, a normal arch, and then pes cavus is a higher arch. Hallux valgus. Yeah, I know it's getting late. Hallux valgus versus hallux rigidus. Hallux valgus is, sometimes you can see this deformity here. What does it look like? A button, right? Mm-hmm. That's what it looks like. And rigidus is limited movement in the sagittal planes, and that usually leads to degeneration. So you get osteoarthritis. You can get osteoarthritis with this also, or you can correct this by wearing shoes with a larger toe box. This was not, and you can see this one is so great, this deformity that this toe is going over this one. And then this toe will also be deformed as a result of this. Hammer toe, PIPs are flat and the DIPs are extended. Okay? That resulted secondary to this. So this house, obviously, the shifting of these bones here causes these bones to shift. So you get flexion of the PIP and extension of the DIP. Mallet toe is just like it was in the mallet finger, an extended PIP and flexed DIP. Claw toe, same thing. Flex, same thing as in the hand. A flexion of the PIP and DIP. Okay. So here's the difference. Mallet toes, hammer toes, and you could see what's happening. Morton's neuroma is, again, this can be caused from tight shoes. Doesn't have to, but it can be caused from heels or tight shoes. And you start to develop the digital plantar nerves on the bottom of the foot start to become inflamed, and they give you pain between the third and the fourth toe. The tissue around the nerve will start to thicken, and it'll start to get irritated and compressed. The patient complains like a burning pain while standing, or they'll feel like there's a pebble in their shoe when they're walking, or they'll feel, like they'll give the explanation like, I feel like I'm walking on a marble, or my sock is bunched up. I keep checking my sock. So they'll complain of pain here. May result because somebody has flat feet or bunions or hammer toes or really tight shoes. So those are things that can cause Morton's neuroma. All right. Tom, Dick, and Harry are the tendons that go posterior to the medial malleolus, right? Tom, Dick, and Harry tendons. And the tibial nerves run through the tongue, flexor digitorum and the what other one? Flexor hallucis. Okay, almost done, line. Substentaculum tali we talked about. We know where that is, and specifically that is there to change the direction of the tendons of the Tom, Dick, and Harry and leads them to the posterior side of the foot. Tarsal tunnel, just like we have carpal tunnel, we have this posterior tibial nerve that becomes compressed in the tarsal tunnel and the tibialis. So all these muscles that we just talked about run through the tarsal tunnel as well as the tibial nerve. And the person will complain of tingling and numbness in the bottom of the foot. Okay? You can have posterior tibial nerve compression, or you can have an irritation here. Bimalleolar fracture is fracture here and a fracture here. So the malleoli become fractured, and a trimalleolar fracture involves the posterior tibia. So we have the malleoli as well as the posterior tibia. Triple arthrodesis is when they fuse the mid-tarsal joint. So what's a arthrodesis is a surgical fusion. So they'll if you have arthritic changes, what they'll do is they'll fuse the joints. They'll fuse the mid-tarsal joint. And a plantar grade foot, the definition of it is just your foot is at right, your tibia is at right angle to your foot. So 90 degrees. Calcaneus foot is when the foot is stuck in dorsiflexion, and that usually results if you're in a fixed cast for a period of time, and that results in difficulty walking. But you have to mobilize the ankle itself, and then the person will be able to walk without difficulty. All right, that's it. Forget this for now. Okay, sorry I ran a little over, but it is recorded, and I'm coming back on tomorrow to talk about massage. So if you have any questions about this, we can talk about it next.
While everyone's here, Professor, can I talk about the lab coat stuff real quick?
Sure.
2 seconds. So I was just there today, and for anyone who still wants to get fitted, they'll be there from 8:30 to 2:30 tomorrow and Thursday, room 208. And I'll send in the group chat Anita's email because she just needs you to email her if and when you're going to go.
Yeah, Chris, I sent a message out right when I got home about that too. Anita said I could also just text her if I wanted, or you guys can email her, or I can send it in one email. So whatever's easier.
Cool. Right
Just
on.
let me know. Yeah. And one more thing, I know I mentioned this in the chat before, but the second year students are